This webinar is co-hosted by the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health and the Asian Development Bank. My name is William Moss, and I'm the Executive Director of the International Vaccine Access Center and will serve as the moderator for today's webinar. Today, you will hear 5 presentations on COVID-19 vaccine effectiveness. You'll hear about next generation COVID vaccines, and you'll hear about broader issues beyond COVID-19 vaccine effectiveness that are important as we go forward. We expect this session to last about 1 hour, but we scheduled longer than that, an hour and a half, but we think we could finish up in an hour depending upon the number of questions. And we want this webinar to be interactive. We encourage you to type your questions in the Q&A box in Zoom, and we will try to get to as many questions as we can. And we're willing to kind of stay on beyond the hour to answer some questions if we have some. Today's speakers will start with Dr. Maria Knoll, who's a senior scientist at the International Vaccine Access Center here at the Johns Hopkins Bloomberg School of Public Health. Maria is an epidemiologist who's worked on vaccines and vaccine preventable diseases for many years and is a leading global expert, particularly on pneumococcal conjugate vaccines. She'll be followed by a pairing of Caroline Walter and Melissa Higdon, who will really dive deeply into COVID-19 vaccine effectiveness studies. Caroline Walter is a research associate at IVAC who co-managed much of this systematic review that contributed to the evidence that you will hear about today. And Melissa Higdon is an epidemiologist at IVAC who has co-authored a number of very important papers on COVID-19 vaccine effectiveness, including being the lead author on a paper published in Lancet Infectious Diseases on the duration of effectiveness of vaccination against COVID caused by the Omicron variant. They'll be followed by Dr. Anurima Bhadia, who is a physician and a research associate at IVAC, and she's going to tell us about the next generation COVID-19 vaccines. And then we'll finish up with Dr. Chris Morgan, who's technical director of immunizations at JPIGO. Chris is a pediatrician and public health physician. He serves on the Western Pacific Regional TAG, as well as on the SAGE working group on COVID-19 vaccines. Before we get started, I want to extend my gratitude to Sherry Morgan, who's led a lot of this work under the Asian Development Bank project, and Andrew Land, who has helped coordinate this webinar. So I'll turn it over to Maria to provide some background on COVID-19 vaccine effectiveness. Maria, over to you.
Hi, Bill, thank you. I'm just waiting to see if I can advance my slide. Here we go. First, before we get started, we first want to acknowledge that vaccine effectiveness is just one of many considerations when making vaccine policy decisions on the use of COVID-19 vaccines, but it's a very important piece because we want to make sure that they work the way we expect them to. Vaccine effectiveness data are obtained from observational studies conducted after the clinical trials for licensure and after the vaccine has been rolled out into the population. They tell us how well the vaccine is working in the real world, but they also answer important questions that the clinical trials did not. The clinical trials were conducted in a particular group of people during a specific time. And after the vaccines rolled out, variants of concern started to emerge. Effectiveness studies showed how well the vaccines were protecting us against these new variants. The clinical trials were also of short duration, and so we didn't know for how long their protection would last. And clinical trials did not provide data on how well they would work in certain subgroups of people or for additional outcomes that were of interest. Going forward, vaccine clinical trial or vaccine effectiveness studies may be even more important since it's likely that future vaccines will be licensed based on immunogenicity data only, meaning no clinical efficacy data would be available. And all such data wanted would need to come from these post-licensure observational studies. This is an example of how much more we learn from the observational studies than the clinical trials. This is data for Pfizer's vaccine for the primary series against severe disease and death. Each dot shown here is efficacy or effectiveness results from a different study population. And circled in blue is the only evidence that we have from a clinical trial. The rest all comes from vaccine effectiveness observational studies. For example, the only robust evidence that we have about how well this vaccine prevented death came from observational studies only. And they provided data on other outcomes, such as asymptomatic infection, transmission, and long COVID. Observational studies also provided information on how well these vaccines were working in certain subpopulations, such as older adults and pregnant women shown here, and others. And you can see the evidence that they provided us on how well the vaccines were working against the variants of concern as those emerged. Many organizations and countries around the world have been monitoring vaccine effectiveness. And we're just a small team at Hopkins that supports the World Health Organization, CEPI, and the Asian Development Bank to monitor vaccine effectiveness for addressing their priority questions to help them make policy decisions and to advise countries. We don't conduct the studies ourselves, but we carefully review the studies that have been done by others around the world. Every day, we're scanning the literature for new studies, which we critically evaluate to ensure that they're high quality so that the information that we get about vaccine effectiveness is as accurate as possible. And we enter all this information into databases that we make publicly available at our View Hub website. And then we analyze the data and communicate a synthesis of the evidence to the policymaking groups. We also summarize the evidence in the form of manuscripts and also briefs that can be understood by a less technical audience. I invite you to go to the View Hub website, where we have abstracted information about each eligible study. For example, here on the right, I'm showing an interactive table where you can filter to find specific studies of interest. We have also downloadable summary tables and forest plots of the studies, as well as a series of briefs summarizing information by topic area. And in addition to a lot of other information on COVID-19 vaccines, we also have information there on many other vaccines that you can explore. We've developed strict inclusion criteria for the studies that we include to minimize bias. Studies have to be published in peer-reviewed journals or in preprint. They must provide confidence intervals around the vaccine effectiveness estimates so that we can weight the studies according to the strength of their evidence. There needs to be an appropriate comparison group to the vaccinated group of interest. The study must account for any possible confounding or bias. The cases need to be lab confirmed, and vaccination status needs to be documented. For those of you interested in conducting your own vaccine effectiveness study, the WHO has provided guidance on how best to do this, which has been adapted throughout the pandemic as the situation has changed. To date, there have been almost 500 eligible studies that meet our criteria from 61 countries published that evaluate how well the COVID-19 vaccines have been working. Most of these have been conducted in high-income countries, but studies have been conducted in all income groups and in all regions of the world. This figure here shows how many studies of each vaccine have been done. Out of the 26 vaccines that are in use in at least one country in the world, currently only 17 of these have any vaccine effectiveness data that are published and meet our criteria. We have a lot of evidence for some vaccines, in particular the mRNA vaccines, but most vaccines in use have little or no data on how well they are working. Now I'm going to pass it off to Caroline and Melissa, who will show you the results of these studies to answer our questions.
All right, so Maria discussed how observational studies can fill gaps in evidence to help answer questions guiding vaccine use. And one major question from the start was about the duration of protection of the vaccines, or how long protection lasts. We couldn't get this from the clinical trials because, as Maria noted, we needed information quickly about vaccine efficacy, and it takes time to answer this particular question. So we looked at this from the beginning of vaccine rollout. This plot on the left shows vaccine effectiveness over time since primary series vaccination against different outcomes shown at the top. Each line in the plots is an analysis of vaccine effectiveness over time from an observational study, and each color represents a different vaccine. We tracked and compiled this information from effectiveness studies, as Maria explained, and we then did a meta-regression with all of this observational data to look at the average declines in vaccine effectiveness over time. And that's what you're seeing summarized in this plot on the right-hand side of the slide. The average declines in effectiveness among all vaccines for any infection, symptomatic disease, and severe disease. This is in the context of early variants like Alpha and Delta. And as you can see on the right, we saw waning of protection for symptomatic disease and infection in the 6 months following vaccination, and some decline against severe disease as well, shown in purple. And just a note that you'll see other plots like this one on the right throughout our presentation. So keep in mind that these represent results of our different meta-analyses of data from many observational studies. This evidence of waning protection prompted many countries to begin offering booster doses. And something we wanted to highlight as well is it's critical to have surveillance systems in place from the start of vaccination, because without those systems, we can't have the data to do these kinds of analyses, making it difficult to make further recommendations about vaccine use. Now, everything I've discussed so far was before Omicron, and as we all now know, Omicron changed the situation drastically. When Omicron began circulating, we were concerned that vaccines might not work as well based on what lab studies were showing about the immune escape of this variant. So we revisited a lot of the same questions we had asked before, like how well do these vaccines work and how long does protection last in the context of Omicron? As we suspected, the effectiveness of primary series vaccination started off lower than for other variants, and as you can see here, it also declined faster, especially for symptomatic disease, shown in this graph in blue, where protection is almost non-existent by 9 months following vaccination. This added even more evidence supporting implementation of booster doses. As you see here, booster doses substantially improved protection against severe disease and restored protection against symptomatic disease. We then observed waning of protection once again, although effectiveness remained pretty high against severe disease. This, along with other factors, led some countries to introduce second booster doses. And we then saw a similar pattern after the second booster of improvement in protection, followed by waning. However, when we look at severe disease in purple, you can see that the benefit of the second booster was pretty small when given 6 months after the first booster. So this had implications for the timing of booster doses and second booster doses, and you'll hear a bit more later on about where we are now with those considerations. Another major question about vaccine effectiveness was, does it vary by vaccine platform and by specific vaccine? Again, particularly in the context of Omicron. So we looked at this question and we did observe differences. Some platforms were more effective against Omicron than others. Notably, mRNA vaccines showed stronger protection compared to viral vector or inactivated vaccines. And even within a vaccine platform, we saw variation in effectiveness between specific vaccine brands. A challenge with answering this question is, as Maria touched on earlier, not all COVID-19 vaccines that are being used have robust evidence available on their performance. The bulk of observational studies look at mRNA vaccines. There's little evidence on effectiveness of protein subunit vaccines, no evidence on newer platforms like DNA vaccines, and little or no evidence for several specific vaccines that are in use. And that also means, of course, that we have limited evidence about the duration of protection for some widely used vaccines. For example, some inactivated vaccines. Another thing we saw from vaccine effectiveness studies is that using a booster dose of a different vaccine platform than the primary series may improve protection. This is known as heterologous boosting. And this did lead to some policy guidance by WHO to consider heterologous boosting with mRNA or viral vector vaccines where available, based on the evidence that heterologous boosting could improve protection. However, the overall policy implications of differences between vaccines and platforms really varied by country. Countries wanted to use vaccines that performed well, but there were many other factors that affected decisions about vaccine use beyond effectiveness, such as availability of different vaccines. And conditions continue to change. We keep seeing new variants and new subvariants, and availability of more and more vaccines that have different characteristics. So going forward, the reality is that some decisions on which vaccines to use will likely be made without robust data on their effectiveness. One other question that we needed observational studies to answer was, how well do vaccines work if you've already been infected, especially as the pandemic evolved and this applied to more and more people? This is a review and meta-regression shown done by another group of researchers that looked at this question of hybrid immunity or previous infection and vaccination. They looked at this against Omicron over time, and the different colored dots in these plots represent estimates from different observational studies that they included in their review. As you see here in the upper plot, they observed that a previous infection alone provided high levels of protection against new severe disease, and it only waned slightly over time. Though you can see in the lower plot that protection against another infection waned much more rapidly. Primary series vaccination on top of a prior infection showed higher protection compared to infection alone, and this was sustained over time for severe disease, though again wanes for any infection. This review also looked at the effect of a booster dose in people with prior infection, and you can see that it didn't add a whole lot compared to the primary series alone. So maybe some improvement against any infection, but again, it wanes quite rapidly. In terms of policy, the recommendation was to vaccinate regardless of prior infection. And this had a lot to do with the costs and the logistical challenges of screening for prior infection status, as well as the evidence that vaccination does at least slightly improve protection. One possible implication was to extend the period before booster vaccination for those who'd had a prior infection, so that the boosters would add more benefit. However, there are many remaining questions for which we don't have a lot of evidence because of all the different variables involved. For example, the protection conferred by multiple past infections, infections with different variants or subvariants, or the order of infections versus vaccination. So I'm now going to pass things over to Melissa, who will discuss more recent questions about vaccine effectiveness and how those are informing current policy recommendations.
Thanks, Caroline. And I am just trying to figure out how to advance the slides here. Okay. Okay, there we go. And so these next few questions are policy questions that WHO had earlier this year. And at this time, the situation was pretty different than it was in 2021 and 2022. And now vaccines are widely available, and we have high population immunity either through vaccination or through infection or through both. And one of the questions WHO asked was about when to give an additional booster dose beyond the first booster to older adults. And this plot shows the average decline in VE of a first booster dose against severe disease due to Omicron in adults 60 years and older. And it's the average decline estimated across many different studies. And the line in purple here shows the average decline in VE that we were seeing from the studies available at the time. And we did see some decline with severe disease, though VE did remain high at 6 months after the first booster. And because older adults are most at risk for severe disease, even a small decrease in vaccine effectiveness can mean increases in severe disease and death. And in the most recent recommendations, WHO recommends additional boosters for older adults, but lengthen the interval to in between boosters to 12 months. And I just want to note here that the exception to this was for the oldest adults. So those are adults 75 or 80 years and older. And then also for older adults with significant comorbidities. And for these groups, WHO recommends to receive an additional booster every 6 months. And then the line in blue is from an updated analysis. It's what we represents kind of more what we know today, includes more recent studies. And we do now see a slightly steeper decline than we did in March, which just tells us that the situation is still evolving and highlights the importance of continued monitoring of vaccine effectiveness and continued updating of recommendations as needed. And WHO also considered whether healthy younger adults needed an additional booster dose. And in March, we were seeing very similar declines in VE of a first booster dose against severe disease that we had seen for older adults. But the WHO does not routinely recommend second boosters for healthy younger adults. And this is really because younger healthy adults are at lower risk for severe disease, especially in this period of high population immunity. And additional boosters wouldn't have a great public health impact, and they wouldn't be very cost effective. But the updated data here in blue again show larger declines, again just stressing the need for continued monitoring of VE and continued reassessment of the COVID-19 vaccine recommendations. And as newer subvariants of Omicron emerged, it was really important to understand if these newer subvariants were resulting in greater declines in protection against severe disease than we had seen with the earliest Omicron subvariant BA.1. And to try and answer this, we compared studies conducted during different subvariant periods. And with the more recent subvariants, we see that on average, VE may decline more quickly in the first 6 months after the first booster, though I just wanted to note the confidence intervals here do overlap for each of the subvariants shown. And I also want to point out that this analysis did not include any studies of the Omicron-containing mRNA bivalent vaccines. The available studies to date suggest a similar or modest improvement of vaccine effectiveness of the bivalent mRNA vaccines compared to the monovalent mRNA vaccine. And currently XBB is the dominating circulating subvariant, and unfortunately it's not on the graph, and that's just because we don't have a lot of evidence yet on VE against XBB. But lab studies show that vaccinated individuals have decreased antibody response against XBB compared to the earlier subvariants. And this suggests that VE against XBB may be lower than what we've seen for the other subvariants. And as new studies against XBB are made available, we hope to get a better sense of how this subvariant might be impacting VE. The results of studies against newer subvariants will be really important in deciding how long to wait for a booster dose, and also can impact recommendations around future vaccine composition. And I just want to draw your attention to 3 really good resources here. The first is the WHO's SAGE roadmap for prioritizing use of COVID-19 vaccines, and this has all the most current recommendations. The WHO weekly epidemiological update, which is actually now published monthly, has a summary of the most up-to-date and most recent VE evidence. And then the View Hub resources page, which also has summaries of the most up-to-date VE evidence. And as we've mentioned, because the SARS-CoV-2 landscape is still evolving, continued monitoring of VE is still needed to help determine best vaccine policies, and especially for our most vulnerable populations. But it's becoming increasingly difficult to assess VE, and I just wanted to mention a few of those challenges. Evaluating VE requires an unvaccinated comparison group, which is becoming harder and harder to find, and persons who remain unvaccinated at this stage may differ in some really important ways that can bias VE estimates. But we can use other vaccinated groups to evaluate how well a vaccine is performing. For example, in trying to assess the performance of a first booster dose, we can use persons who received a primary series vaccine as the comparator to get at the added benefit of that first booster dose. We could also compare persons who received a second booster dose to those who received a first booster. And this is what we call relative VE. We can also compare disease events in persons receiving one vaccine product to those receiving another vaccine product. But with variability worldwide in terms of the comparator groups and in terms of new vaccines being introduced and evaluated, the generalizability of these studies to other settings and countries may be limited. And so countries might have to do their own monitoring of VE. Increased population immunity can really complicate measurements of VE, and declines in testing and in the reporting of test results make documenting previous infection difficult. And not knowing who in a study might have protection due to a prior infection or multiple prior infections, it can bias VE results. During the pandemic, a lot of progress was made in establishing a global system to detect emerging variants. And as a result, we've had a pretty good idea what the circulating variants have been, and have been able to rapidly assess the risk they pose. But now we're seeing substantial declines in genomic sequencing, and without knowing which variants are circulating, it will be difficult to tease apart the natural waning of VE versus declines in VE due to the emergence of new variants. And this can also hinder comparison of newer vaccines to older vaccines introduced in different periods. With the end of the emergency phase of the pandemic, funding may be harder to come by, particularly in light of competing health priorities. And finally, some countries may lack the systems to monitor VE, and some vaccines may be used only in countries that lack this capacity. Despite these challenges, if some of the progress made over the course of the pandemic can be maintained, we hope they can continue to monitor the performance of current and new vaccines as SARS-CoV-2 continues to circulate at high levels around the world. And I'm going to stop here and turn it over to Anurima, who is going to talk about new COVID-19 vaccines in development.
Thank you, Melissa. Hello, everyone. I'm just going to take a moment to see if, we are good. Hello, everyone. We are going to transition and talk about the next generation of COVID-19 vaccines in the pipeline that are designed to address key challenges faced by current vaccines. We have never been in this situation of vaccine innovation for any other disease before, where we have around 50 different vaccines that have already been approved for use in every country globally, and more vaccines are coming. Some of the vaccines using next generation technologies have already been authorized for use by some countries, and we are excited to see how they perform. Most of the next generation vaccines are aiming to overcome logistical challenges that we have experienced with mRNA vaccines and are designed to be more stable at varying temperatures, including room temperature. This would enable easier transportation and distribution to remote and resource-limited areas, facilitating global immunization efforts. Adaptability is a key focus of the next generation of vaccines. The mRNA bivalent vaccines targeting Omicron subvariants and the monovalent XBB vaccines that are currently in development have shown us that there are technologies that can be adapted to address emerging variants. We now have many other platforms like protein subunit and viral vector vaccines in the pipeline that target circulating variants. Some next-generation vaccines also aim to minimize potential side effects by reducing the required dosage. By optimizing vaccine formulations and leveraging advanced delivery systems, it may be possible to achieve comparable or even improved immune responses with lower vaccine doses. Lastly, injection-free techniques offer potential advantages in terms of ease of administration, acceptability, scalability, and also have the potential to reduce viral transmission. Intranasal vaccines have already been approved for use in countries like India and China, and we are excited to see more newer technologies that are in the pipeline, like oral pills, transdermal patches, and sprays. So currently, there are over 300 vaccines in different stages of development worldwide, and at least 68 of them are in advanced stages of evaluation. This is from publicly available information, so the actual numbers may even be larger. There have never been so many products in development targeting a single pathogen before. Even if most never get scaled up to production and use, the choices may seem overwhelming. So in this graph here, we can see the 68 vaccines that are currently in late stage development grouped by their platform type. Some of these platforms colored in blue have already been utilized for COVID-19. And as my colleagues discussed, we have observational data on their performance in real world settings. Some others that are colored in green are novel for COVID-19 or have only received authorizations recently, such as for the virus-like particle vaccines, but are technologies that have been in use for other pathogens like hepatitis B and HPV. We have no previous experience with DNA technology, and we are looking forward to seeing how they perform. As described by my colleagues, it is critical for us to continue monitoring vaccine effectiveness for all vaccines as the COVID-19 pandemic continues to evolve. But this is particularly true for the new vaccines with which we have no past experience. Certainly, not all the vaccines in development are going to be an option in the future, but even if it's a small fraction of these, we want to emphasize that this is still many more choices than we have had for any other vaccine. Lastly, while the next generation of COVID-19 vaccines offer promising advancements, they are not without their challenges. In addition to challenges in measuring vaccine effectiveness, there may be bottlenecks in manufacturing, supplying, and distributing vaccines, not to mention regulatory approval challenges. Additionally, for countries that want to deploy their locally manufactured vaccines, building public trust and addressing vaccine hesitancy are ongoing challenges that countries may face. Another challenge that may arise in the context of new platforms moving forward is the potential lack of initial demand for COVID-19 vaccines in general, which may lead to poor uptake of these vaccines. Thank you very much. I would like to pass it over to Dr. Chris Morgan to talk more about other important considerations apart from vaccine effectiveness in helping guide policies.
Thank you very much, Anurima. Okay. Andrew, I've gone into annotate mode. Were you able to advance the slides for me? Thank you. So particularly recalling Melissa's update of the key evidence to policy considerations about vaccine duration, boosters, and so on. I think that has been highly valued, particularly from my point of view at the SAGE COVID vaccine working group. And as I've been tracking across the 30+ country offices that Chipago has, and also the viewpoint from the Western Pacific regional tag, I think that in terms of putting this vaccine effectiveness evidence into practice, and particularly over the next period of time, in front of us raises challenges in 5 key areas. Managing the transition from emergency to routine, the refocused prioritization of who to vaccinate, the need to maintain and broaden innovations, and the need to really think harder about integration with other services, and then clarifying our future needs. And I've got 5 slides on each of those topics. Next one, please, Andrew. So I think the virus, the disease, is still with us and continuing to circulate. But as we all know, the emergency has been declared over. And I think this puts us into a phase transition, so-called, where this one change from emergency to routine will affect multiple parts of the system and immunization programs. Policy supports are changing as those emergency committees are wound down. The financial supplementation that lets programs not just receive and procure for themselves vaccines, but also a whole lot of other programmatic supports. Those are changing for countries and have been over the last 6 months. And given that the need to continue with vaccination is very clearly there, as we've seen in the effectiveness evidence, countries are needing to plan for longer term availability. In different countries, the emergency use licensing and approvals have had different timeframes, and countries are grappling with how to update those. Also, how to ensure supply, especially, as we've just heard, with a likely expansion in the number of product choices on offer. There are critical decisions for countries on how to finance those into the long term. And again, with the range of products, that some of which do continue to need specific cold chain supply and distribution requirements, how to maintain that is into the longer term is also a challenge for countries. And as the management of COVID vaccination reverts back to in most countries, the usual immunization program, there is the challenge to prioritize accurately based on the latest effectiveness evidence, and to keep and expand the innovations that have been brought in. Next slide, please. So as Maria put the link into the chat for the WHO SAGE roadmap, and this roadmap from March really looks at what are the recommendations when there is substantial population immunity from either wild infection or vaccination or both, and also in the context of the evolving Omicron and other variants. Really, as we've heard, the focus is now on older persons, those with chronic disease, pregnant people, and healthcare workers, given that they are more exposed and that we owe a duty of care to them. And that we don't know exactly the schedule, but there are going to be repeated doses to accommodate waning immunity. And refocusing to these population priorities is really a managerial necessity to optimize resources, but it's also part of the need to make sure the vaccine is used where it's going to give the greatest benefit. Next slide. And a big part of maintaining this focused prioritization is to maintain some of the innovations that were brought in during COVID as a critical need to start with, to think hard about which innovations were needed just for the emergency phase and do not really add value to routine programming, and which innovations are really essential to continue into the long term. And I'd really suggesting 3 key areas for those that really add value to routine programming. I think we have learned a lot about what drives confidence or lack of confidence in vaccines. And we've seen a lot of innovative communications in social, mass media, and traditional interpersonal communications. And we really need to see the continuation of the high-level support for vaccine effectiveness, and maintain some of those innovations, such as being able to respond to community concerns. And I think in particular, response to community concerns is linked to the innovations around provision of real-time information that is available to the public. And I think the View Hub data on vaccine effectiveness is one really important example of publicly available scientific information. But at the program level, many programs for the first time have been able to track quite finely where vaccines are going, how much they are being what the uptake has been like in different subnational settings, and what needs to be done to revise subnational distribution and supply. And those innovations in tracking real-time supply information and their usage will be incredibly important over the next period of time. And perhaps most important, and previous speakers alluded to this, is the need to continue innovations, particularly in electronic information systems, and particularly data linkage that connects the disease data with program performance, that maintains and extends the gains we've made in registering these new populations for vaccination and tracking them for booster doses. And also, we've seen many countries extend their capacity to both track adverse events and to do good quality causality assessments. All of these are important for the program to build confidence, but also important so that we continue to collect data on how the newer vaccines are performing, both in effectiveness and in other aspects of their uptake. Next slide. And it is also clear that in responding to the recommendations and the science on vaccine effectiveness, that means repeated doses for specific population groups are going to be needed, that many of the service delivery models that were innovated during the emergency response, these mass vaccination centres, huge public forums or facilities for vaccinating large populations quickly, many of them countries are finding just cannot be sustained in this next phase following the emergency. And many countries do not, prior to the pandemic, have the history of vaccinating, for example, older adults or regularly reaching those with chronic disease. And in each country, the history that they have of reaching priority populations will play a strong role in determining future options. History perhaps in whether the country has strong community expectations that preventive care will be made available to older adults, whether countries have a history of vaccinating adults or not. We're roughly at 50-50, particularly considering low and middle income countries in terms of having countries with no past history of adult vaccination. And clearly this also will raise the need to explore integrated platforms, and particularly integrated platforms that focus on the preventive primary healthcare, whether it's around cardiac disease, diabetes, nutrition, other chronic infections, but all of which have key preventive screening, counselling or preventive treatment options, linking those to COVID vaccination and linking COVID vaccination to other adult vaccines is going to be increasingly important, both to encourage community confidence and uptake and to manage program resources. And I just wanted to note a couple of WHO guidance pieces on integration with primary healthcare and on the vaccination of older adults. Next, please. So lastly, I just wanted to encourage any country program management colleagues who are listening and will be continuing to reach out through WHO and other channels to continue to provide their input on the policy and practice gaps where we really do need evidence. And we've heard that from previous speakers that the evidence gaps are continuing, and that they're particularly around vaccine effectiveness and the ideal schedules for repeated vaccination. But beyond that, we're going to need to continue to collect implementation experiences in this post-emergency phase, particularly around things like how to finance sustainable vaccine supply, particularly thinking perhaps of smaller countries where pooling arrangements that go beyond Gavi for those who are not eligible for Gavi support will become important. Maintaining adverse event reporting systems and making sure that these are linked wherever possible to regional and global databases so we can continue to build that confidence and document multi-country experiences. We still don't know a lot about co-administration with other vaccines, and country experiences with that will be important to document. And as I mentioned already, the maintaining surveillance systems that link disease reporting and program performance monitoring will be essential to our continued learning. And we also will be really on the alert for service delivery models, particularly ones that do show effective integrated preventive primary healthcare platforms. And the next generation vaccines, Anna Rima mentioned, we're going to need similar cycles of evidence on vaccine effectiveness as we've seen with over the last year or so. And as the variety of products available continues to expand, which seems likely, tools to actually support countries on product choice and also making pragmatic decisions about their schedule options will also be critically important. So those were just a few thoughts to extend the vaccine effectiveness evidence into some of the policy and practice decisions that countries are grappling with. Thank you. And I'll hand it back over to Bill.
Thank you very much, Chris. And thank you to all of our speakers for this wonderful, very concise synthesis of insights into COVID-19 vaccine effectiveness and beyond. I encourage our listeners to place questions in the Q&A. I'm going to start with a question and then use that as a segue to, I think, two similar questions that were placed in the Q&A section. And so, the broader question is, should all countries perform COVID-19 vaccine or conduct COVID-19 vaccine effectiveness studies? And one of the striking things from the map that Maria showed was, I think, the paucity of studies coming out of sub-Saharan Africa. And so that's kind of part A of the question, but then I'm going to link it to two questions in the Q&A around what are if we need more diversity, geographic diversity in vaccine effectiveness studies, what are the health system needs in those countries to be able to do vaccine effectiveness studies that would meet your criteria for inclusion? So it's a complex set of questions, but I'll kind of put that out there and see.
I'll struggle with answering that one, unless Chris, you want to take that one first?
I will jump in because I'm just seeing Meru Shields' question in the chat as well, which I think is linked.
Yes.
And I think there's two things on the table. There's vaccine effectiveness studies that meet the IVAC criteria for inclusion in ViewHub and in those consolidated briefs. And clearly, they require a higher level of data availability, but also of perhaps research capacity. So it's going to be difficult to do them universally, but there is a real need, as Miro implies, to make them happen in the breadth of countries that are experiencing COVID vaccination. But I guess I'd like to challenge the IVAC crew with the second thing on the table, which is, clearly every program in every country needs to continue surveillance, tracking disease, tracking program performance, trying to put the two things together. And even if that work doesn't meet vaccine effectiveness study, is not a study in its own right, it will raise hypotheses and maybe raise alerts as to places where things are not going as expected and where deeper study is going to be warranted. So some multi-country, regional or global tracking of those outliers or anomalies from surveillance data, I think, will be really important as well. So I've just made your job a little harder, Maria.
Or easier if we're just doing disease burden surveillance and not doing vaccine effectiveness evaluation, then maybe we're not needed. I think you're right. I think, maybe the gap that we see in Africa is because, maybe they had the least problems, or maybe the last to have a problem. And it reflects that. It certainly, they've always struggled having so many low-income countries there with capacity to spend resources on monitoring instead of treating disease, and spending their efforts on getting the vaccines out. But one of the things I think you mentioned, Chris, is electronic record. And if we could move globally to make that happen, everybody has cell phones now. The technologies are just getting more flexible. It's around, the corner, hopefully where that would be more possible to look at serious disease, tracking that, and to monitor the vaccinations. And that goes for all vaccinations. I think we all acknowledge that our estimates are very poor in estimating, coverage and who are the children who are or under immunized. So it would help for many things besides COVID. I'm not sure if anybody wants to add anything to that. I do think that it's unlikely that all countries would be able to measure VE. I think it's a really difficult thing to do. I know that there's thousands of studies that we've combed through, and a fraction meet the criteria of being good enough to use for these purposes. But that's not to say that those studies also, we don't learn from those studies.
Great. Maybe
Yeah, I don't know if anyone else.
Yeah. Maybe to kind of follow up, a number of the speakers mentioned, the importance of trust in vaccines and demand, and, vaccine effectiveness is part of that, but vaccine safety is another. And maybe you could tell us whether these same studies are informative on vaccine safety outcomes. Are they measuring that in these studies, and are there valid inferences on vaccine safety to be made, or is that a different exercise?
I'll speak. I'm curious. Anya and Caroline read like every paper that comes out and what they've seen. We were on View Hub. We also have a module on COVID safety where we've done a lit review and abstracted studies that we didn't extract so much focus on what the results were, but who was at least looking for something. If there was something happening, would they be able to detect it? And one of the problems that we found by looking around at the internet is that there's many more things being talked about, not in the journals, the scientific journals, or maybe not the place where a lot of these events are being reported. Not that there's a lot of events, but if there is an event, writing a journal article about it is not the thing that people do. They would post it on their website. And so we've gone to the US CDC and other places to try to get a sense of what kinds of safety events are being reported there, but the monitoring systems, I think those are also challenging. Many countries have that for safety. To me, it's a different system than what we do for monitoring, the events that happen as a result of illness, as opposed to the event that happens as a result of vaccination. And also for COVID, how those are often events that happen without vaccination. And so then it's really difficult to tease apart what's the excess risk that was conferred by vaccines. So it's even more analytically and just scientifically difficult to sort that out.
All right. Anything?
And we have another webinar on safety
Yes.
coming in a couple weeks.
Yes, we should promote that. We do have a webinar planned on COVID vaccine safety. So
Yeah.
the
Can I
audience
just make one systems comment on safety? And I think I'm joining from India, and we've seen the application of an innovative approach that uses these electronic means and mobile phones for reporting to significantly improve in certain states, particularly Madhya Pradesh, I'm thinking of, the reporting of possible adverse events. And two tools have really been important in that. One is using digital means to promote more active reporting and active tracking of possible adverse events. And we saw a jump from what was clearly underreporting to an expected level of reporting of possible adverse events. And then the other is the application of machine learning in the analysis of multiple reports to actually detect trends and locations. And I think both of those things are going to be increasingly important and are linked obviously to the electronic surveillance systems. And Bill, if I can, I'll just comment quickly on the question in the chat that Bikash raised around a really important question, and I interpret it as the interaction between human behavior and vaccine effectiveness. And I think we see two elements. One is that people's understanding of how effective the vaccines are determine how likely they are to take them up or to maybe recommend them to their older family members or to other family members who are living with chronic disease. So I think the clear communication of why and for whom a vaccine is beneficial is so important. And then the other is that we see quite commonly, even if we have priority age groups, sometimes people from outside those priority age groups slip into the vaccination program for a whole range of different reasons. And so program data that tracks whether the program is reaching the priority groups and making sure that those databases allow us to track the behavioral element in terms of who's taking up vaccine, I think is going to be really important, much more important now in this post-emergency phase where we are targeting particular population groups. Thanks.
Great, thanks. Would anyone else like to comment on Bikash's question on how human behavior or tendency affects vaccine effectiveness? Or me?
I know this group has a lot to say on that.
Yeah.
I'll just say that I think that's it's always a question that's in the back of our minds when we evaluate vaccine effectiveness studies and look at the data. It's really hard to measure, but we always wonder, when we're not seeing the declines we were expecting in older adults, is it because of behavior, that they're less likely to interact with other people, and we're not seeing the declines that we thought we would. But yeah, I think it's a really interesting question, and I hope we can maybe address it in the future.
Great. Maybe I'll ask. We have 1 minute left to the end of the hour. So actually, maybe what I'm going to do is just take a moment, because we were talking about vaccine safety, to let the audience know that IVAC and the Asian Development Bank will be hosting another webinar as part of our webinar series on COVID-19 vaccines. This will be on July 27th, and we'll be sending out information, and it's titled Learning from the COVID-19 Pandemic, Emerging Priorities in Vaccine Safety and Pharmacovigilance in Asia and the Pacific. So keep an eye out for that, the announcement and the link, but that's July 27th, the vaccine safety webinar. I don't see any more questions in the Q&A. Maybe one that I'll ask is, there was a lot of interest early on with the introduction, particularly from the early trials, that perhaps these vaccines would reduce transmission as an outcome. So in terms of vaccine effectiveness, you talked about, vaccine effectiveness against infection and against severe disease and death. I'm curious whether you came across any studies that had transmission as an outcome, and whether there's enough evidence there to comment on that. Anyone want to
Yeah,
take?
I can take a stab at that, and maybe others can add. So yeah, we transmission studies are something we also track and have summary tables on ViewHub that are available, track or summarizing the studies that we've come across. Transmission is sort of even more challenging in that people look at transmission in different ways, and the variables just kind of add up even more. So we haven't actually done a formal analysis of the data that we have on vaccine effectiveness against transmission. But in general, what we've seen is the vaccines are not super effective at preventing transmission, particularly once Omicron came along. I don't know if anyone wants to add.
Yeah, just to add to Caroline's point, and it was a little bit challenging for us to even tease out the differences by platforms when it came to viral transmission. But yeah, but we also look at these studies weekly when we are doing the review.
Great.
But there is some effectiveness against transmission, so they're not, completely ineffective. That they do prevent some.
Great, thank you. Well, I don't see any more questions in the Q&A. One just came in from Prasad. What data suggests about vaccine efficacy, effectiveness in immunocompromised populations? So maybe you could comment on your findings there. Did that come up in your reviews?
Do capture those. I don't have a whole lot of. I don't know that I can add say a whole lot about them. We do capture them. We have forest plots of all of the studies that looked at immunocompromised on ViewHub. We haven't, like the transmission, we haven't done a formal analysis looking at those studies, but I think generally we see decreased vaccine effectiveness with those groups as we would expect. I don't know if anyone else has any other thoughts or comments.
I imagine one of the challenges with that is that there's such a great diversity or heterogeneity in what is meant by immunocompromised, and so it can be hard to tease that apart.
And
Also, those folks know they're at risk, and they tend on taking other measures instead of just vaccination, and that makes what is due to vaccine versus what is due to social distancing and other things that they might be doing difficult to tease out.
Mm-hmm. Great. And then there's a question from our very own Lois Priverdum on surveillance systems. So what types of strengthening is needed to ensure that countries have improved capacity to track disease in older populations? So maybe, and integrate disease surveillance for older adults with existing platforms. Chris, is that something?
I think thanks, Lois. So I think that's part of the transition from emergency to routine, in that a lot of countries did set up registration platforms for older adults, and the challenge now is to take them out of the emergency policy response framework that they're often introduced in, and bring them back to the broader immunization program tracking. And one reason I had a few photos from Mongolia is that they're one country that is really actively working on this process, that They did a great job of electronic information systems for the emergency response and are now working hard to make that part of the broader immunization program. But it's a challenge because the information systems for the existing immunization program are focused on children under 5s, pregnant women, the traditional age groups. And so there is some redesign of the system needed to incorporate older age groups and maybe to allow tracking of whether there are additional chronic disease. For many systems, even tracking pregnancy is not automatic in the data systems. So there is some guidance from WHO on this, but I think we're going to need to see a focused area of support from other development partners. And from my position in Wipro, it's particularly important in the Asian region, where the capacity to do this merging of data systems is already there, but doing it well and making sure it gets done will need, I think, some additional guidance and additional support to countries to for staff time to do that redesign and to test out a few different models and share good models of integrating older adult tracking into systems, particularly picking out countries that did not have a tradition of influenza or other vaccination for adults already in their system.
Great, thanks, Chris. Well, I'm going to, once again, thank our speakers for very concise and clear summaries. And I want to say to our audience that it would be impossible to overstate the amount of work that actually underlies what you're seeing, this crystallization of a tremendous amount of work. As Maria said, screening more than 1,000 articles a week to synthesize this down into, a very concise story and very important policy implications. So there's a tremendous amount of work, and I want to thank the IVAC team for doing all that work and really providing the global community, the World Health Organization, the Asian Development Bank countries, this very concise synthesis. But there's, as the speakers pointed out, there's still a lot of work to be done going forward as well. So thanks to all of you for listening. Thanks to our speakers. And remember the next webinar, July 27th, on vaccine safety and pharmacovigilance. So thanks to all of you.